We don't have any open questions. How about we ask the panelists themselves any comments that they want to bring up or follow-ups once we saw each other's presentations? Anything that comes to mind of either how the data can be used better, how can the data be collected in a better way in terms of the study designs, new challenges perhaps that can be addressed using precision health participant data, opportunities, I guess, to develop new methods and new approaches that come to mind?
I think actually there are some, before we jump into that, maybe there are some questions in the chat that would be, I think I forget that it takes a while to type sometimes. So
yeah. Okay, yeah, they're flooding in right now. The first one has.
I can take that first one. So it says, I had an experience as a patient getting a prescription and discharge for opioid medication, but unlike other prescriptions, it was not called into my pharmacy. The thought was I wouldn't get it filled unless I needed it. This is not taking into account that I live alone and that I could not get the med 24 hours a day. How are your algorithms taking into account patients' living situation? We do take into account living situations as they relate to whether people discharge to home, whether you go to a home or whether you go to a care facility of some kind. We've also used some national data to take into account what you're talking about, which is this, I've got a prescription, but I'm not sure I want to use it. We can't really ever, there's no easy way to say, I got a paper prescription and I took it home, but there are actually data to say that the majority of opioids are actually filled when given, even the just in case. But interestingly, a couple interesting findings that are related. For dentistry, the number of prescriptions actually increase on the Fridays and the day before holidays, suggesting that dentists are actually prescribing more just for that just in case, but actually maybe without indication and maybe more inappropriate prescribing. The other thing that's interesting, and I think has a policy implication, is that there are many states without any regulation as to when that paper prescription you had to get filled, with some allowing you to go fill that 6 months later, even though it was indicated for something very specific. And in a state like Minnesota, where they actually made a policy change to stop that, to make it so that you couldn't, they actually saw that that the policy actually decreased that rate of getting a delayed prescription. So I think that's interesting. But yeah, I mean, there's many things as you can imagine to take into account, and a person's living situation is really important. And then we do have some patients, not the entire cohort, with measures that measure things like social support that would get at some of that in terms of access.
Thank you for that. We'll give the participant time to type more questions. The next one comes from the next one comes from Mary. What is the way to work collaboratively across campus regarding opioid use disorder? Now, obviously, there is quite a few scholars working in the health sciences as well as in the basic sciences, quite frankly, that study pain perception, opioids, and so forth. So I guess the question refers to us as investigators. How can we enhance the collaborative aspects of working across disciplines, obviously, to improve outcomes?
Amy, I'll start, but then I'm gonna kick it over to you. I mean, I would say right now the opioid use case, just so people understand, currently works across 7 schools and colleges, and about 15 of the departments within Michigan Medicine. And so I think in many ways we are directly collaborating across campus with an ever-growing presence. But I think we are in process. And Amy, just to let people know that you and I are out there trying to do this, at least trying to push something together.
Yeah, we're at the early stages of essentially this idea of how can we, there's so much strengths here in this area across the University of Michigan. How can we make that come together in a cohesive way, become more than the sum of its parts? And I see that in 2 ways that we're trying to address. One is the how can we work across the stages of scientific development and discovery because there tends to be a little bit more of specializing of I'm basic science, I'm clinical, and getting more translation across that more rapidly is one, I think, goal. And the other is more impact. So there's a lot of opportunity right now in this area of opioids. So much interest, so much policy change, so much, frankly, federal and other resources going towards programs and trying to see how the university can serve, especially with all the subject matter expertise and guiding what happens around the state more.
Sounds good. Now, the next question is very thought-provoking. It says, what are the differences, similarities, synergies between, quote, precision health and, second of all, precision medicine? How can the differences affect treatment and research studies?
I'm sure we all have different opinions of this, and so I'll take a crack because I was at the table when precision health became a name, and I won't claim to have come up with it because I think precision medicine is the more typical way to think about this. I think when you say precision medicine, though, right now in the United States, whether right or wrong, most people jump straight to genetics. And I think there's so much about the characteristics and phenotype of a person that can tell you about outcomes and or risk and health when compared to genetics, which might tell you more about particular treatments and maybe biology. But I think precision health gets it when compared to precision medicine, because you could take that broader view of precision medicine. Precision health, I think, in the spirit of this initiative, is to try to think more broadly than genetics or biology, but start to account for some of the questions that we've seen in here of like, how do we account for a person living at home? How do we think about people's social support? How do we think about environment? And how do we bring in researchers and that represent the broader aspects of what constitutes health in real life? And so I think that's the difference in terms of the way I would say it. I don't know if either the Amy's have a specific thought beyond that.
No, that's good.
I would just echo and add from a precision medicine perspective, genetics is often what people jump to first, and obviously what I spend a lot of my time doing, but genetics is only a piece of how a person responds to a medication. And so very rarely is that genetic factor the only thing that we would consider when we're thinking about what medication is best for the patient. And so I think it's a major aspect of precision medicine, but precision health just more broadly encompasses all of those characteristics that we think about when caring for patients.
Okay, thank you very much. There was also a question or a note from one of the participants regarding michiganopen.org. One of the patient section links seems to be defunct. So we can have a look at this and make sure the link is properly set. Thank you for reporting that.
Yeah, thanks. We'll look into it.
Yeah. Betsy asked the question, how do you think healthcare and medicine will change in the US as a result of precision health studies like these? Specifically, do you see that real world evidence will increase consumerism of health, probably, a shift from sickness to health focused in care, and the application and viability of very costly interventions, obviously making the top treatments available to everybody across the board is going to have significant ramifications, aside from the economics and the equity, right? There is a lot of moving parts here. So would anybody care to speculate do you have a crystal ball where we can look at and kind of, try to predict where we may be heading?
I mean, I can speak from the pharmacogenetic side. I think most of the work here is really focused on prevention of adverse events to medications, and so things that we can prevent from happening that cause patients to experience things that make them, not feel well or take time off work or be hospitalized for adverse events or things like that. I think it's really been a focus on preventative care so far, but I would hope in the future that, we can also be proactive in terms of, developing personalized treatments that I touched on briefly, not the focus of my work, but what others are doing. And that's certainly an advancing field that is a part of practice nowadays.
I think some of that question touches on cost, right? And I think for the mental health area specifically, where people tend to cycle through lots of treatments before they find one that works, there's a huge potential benefit cost-wise to figuring out the right one the first time, right? And being able to shorten length of care and things like that. So I'll restrict my comments just to that one, because that's that alone, I feel like I'm out on a limb a little bit of guessing.
Okay, I think the next one is for you, Emmy, as well. It says, might the prompt study team consider study participants that are seen through U of M continuing care clinic at RUB?
Yeah, that's a great question. I think we may currently, based on the way we identify people who are eligible, but I will check and look into that, because it would be good to make sure we're very comprehensive.
Very well. The next question is regarding precision medicine encompassing gene therapy potentially. Genetic engineering, gene therapy.
So I will say this is not the area that I work in, but I think it does fit that broader definition of you're identifying a characteristic about a patient that makes them more likely to respond to a certain type of treatment. And so I think it does fall within that definition of personalized medicine or precision medicine. It's not personally what I work in, though.
Yeah, I'll say the same. I mean, I'm not an expert here, but what I'll say is that we're seeing technologies come along, and I think about some of these things like early blindness, where there's a clear genetic factor, and so some technologies are coming along that I don't want to weigh in on whether they're efficacious or not, because I don't have content knowledge. But I think these are where larger data sets are required, and to be able to even start to understand what genetic factors might actually be playing a role in disease versus those that could just be noise. If you look at a very small group of people, this finding may actually not replicate. So I think one thing that was mentioned today, but I think needs to be emphasized, Rachel definitely mentioned this in the introduction, but MGI has been connected in terms of results with data sets across the world. And through that, we can make deeper discovery. But I don't know, we don't currently have any gene editing studies with MGI that I'm aware of.
Thank you. The next question is in regard to methamphetamine and various synthetic drugs that alter mood and perception. Is there funding on the horizon for MDMA research to be used among depressed patients to quote unquote reset brain function?
Go ahead, Chad, if you have thoughts.
Well, I think some of this is already happening, right? Maybe not in the way people think about it. So ketamine is already being used in depression centers for refractory depression. And then psychedelics are being studied more broadly. I think there's a lot of funding on the horizon for this. And I think the Center for Psychedelics and then the combination of that with the prompt study does offer some unique opportunity for next steps for thinking about psychedelics and drugs like ketamine for treatment. Sorry, Amy.
No, that's a better response than I could have given, other than to add that, and that is a notable shift in the last few years, the acceptability and feasibility of both doing those kinds of studies and funding sources that are not like advocacy based.
Thank you. Next question is a question that asks whether we envision precision health and all of its power helping to reduce health disparities, I suspect not only within the state, but within the nation. And if so, how?
I mean, we want to. I think we hope that it will, and I'll say that if we have, one thing at least I'll talk about within the opioid use case is that we think about not just what works at Michigan Medicine, but what are the unique characteristics of hospitals around the state, different places where people come for care. I would say this is true within the naloxone work. What was going to work in an emergency department like Michigan Medicine's emergency department was very different than the small rural, which is very different than the busy urban. And so I think that diversity, equity, and inclusion is fundamental to everything that we do at Michigan Medicine. There's been I think it's been more than just lip service in terms of want to ensure that our work, always has a DEI focus. But I think that, there are certainly inequities across medicine. We've seen it a lot in the opioid use case with an ever-changing narrative. And so I think that's one advantage of not just working at Michigan Medicine, but really trying to work across the state and thinking about what care looks like across the country. And also, who gets care and who doesn't. Amy's probably got a more thoughtful answer than that.
So yes, I definitely think that's this is something that's very forefront in the way precision health is oriented and organized at the University of Michigan. And certainly there's a good argument to be made that it can help reduce health disparities by making treatment decisions that much more objective rather than subjective, right? So, Chad and I think it's come across, both work in pain research some, and there's big health disparities in pain in terms of patients who are Black just receiving a lot less treatment, a lot less pain care, including less opioids than white patients, and for reasons that studies have explored and found really have biases, stigma, racism underlying them. So if you can, through a precision health framework, develop treatment algorithms that take the decision-making out of the framework of someone's biases coming into it, that's great. The challenge with that is that, of course, when you're developing these algorithms, the data you're developing on them can have biases too. So, work in opioid use disorders has shown that when you look in notes for Black patients, there's a lot more assumptions made about this person's drug seeking than a white patient. So I also know that there are people within precision health working on that specific topic of fairness and bias and in artificial intelligence and machine learning and algorithm building to make sure that we don't, kind of have the garbage in, garbage out of perpetuating disparities with the types of data we use.
Thank you. Next question comes from Mary, who asks, what type of clinics are patients with anxiety and or depression recruited from for some of the PH studies? She says, seems like school-based health centers and federally acquired health centers may be attractive places to recruit based on age groups that struggle with anxiety and or depression. And I would add to this, especially in the last couple of years, once the kids were totally isolated and literally immobilized. So any comments or questions you guys want to bring up?
Yeah, for sure. So on the school-based front, so we do recruit from the University Health Service that treats University of Michigan students. At this point, we just do our data collection with UHS and then also with outpatient psychiatry, because both of those are on the same medical record system. So in terms of this precision health approach, where we're needing that high density data across multiple different forms, so far we've stayed within U of M. I would love to expand to FQHCs in the future, in particular, as it becomes possible.
Thank you, Amy. Next question asks if we can share or quote sell our pharmacogenetics data to the feds and or other institutions to answer probably bigger questions by aggregating data from multiple sources. So that is certainly something that increases something known as the statistical power to detect smaller effects. but I would like to hear what you have to say in terms of, sharing, selling, aggregating, harmonizing, pooling data together with other institutions or the feds.
I mean, I'll take that on because my name is on the back of 68,000 consents. And so I think about this all the time and have been at the table from the beginning. And I'll just say that the ability to share data and advance in order to advance knowledge is critical to any biorepository. However, each case, each situation requires some level of unique thought to ensure that ultimately participant privacy and your individual privacy are maintained and respected. That said, I think often we spend more time worrying about protection and that patients and participants, people like the people in the call today, really want to ensure that the data are used and used well, used maximally. And I think that's been the biggest culture shift that I've seen, not only here locally, but nationally, is not to give up privacy or stop thinking about data privacy, but instead to just say, hey, we really need to be accelerating efforts to maximally use these data to ensure that the maximal benefit from participation is seen. And I still think sharing individual data is challenging, but we're seeing more and more ways to do this. And we haven't talked about the data office today, but the data office is a really unique piece to the University of Michigan and very innovative and thoughtful, not only in the way that they potentially can remove identifiers to share data, but also even just let people come in via a portal into the Michigan system so your data don't leave, but that things can be done by external investigators that don't always require the expertise to be here. And I think those are unique opportunities that respect the privacy of the data and the security of the data while still advancing knowledge. So it's a complex question, one that's been an ongoing conversation for a decade. And I don't know if I did it justice, and Amy, if you have any further thoughts, please weigh in, but certainly this has been one we've been talking about for a long, long time.
Thank you. Now, another question that's quite interesting here and does come up often is this question of concerns about adoption of AI, precision medicine, precision health techniques, tools, instruments, and if we know or are aware of unintended consequences of their application. I mean, think about self-driving cars, right? We've known for at least a decade how to build a self-driving car. Why are they not on the road? Well, because there are concerns. So something very similar is what Betsy is asking, whether we have any qualms or reservations about any of the precision health and precision medicine AI techniques in terms of clinical practice, unintended consequences.
I think there's always the potential for unintended consequences. We keep the Henrietta Lacks book in our library for all the people, all the coordinators who recruit and who help consent patients. We talk about the things that can happen to data and the importance of making sure people know the potential for the data. I think this is a part of the reason that our consent, and this has been a struggle back and forth with ethicists. I think the great part is our ethicists are at the table and we're talking about this, is trying to be honest about the potential for something to change over time, meaning that an advance in science, an advance in technology that would allow things to be done. I think that's part of the reason that there are clear limits on some of the things that can be done, but at the same time, it's not such a carte blanche that we can just run off and do anything with data or samples that we want. So there are ethicists, there's committees, there's checks and balances. But I think the point is well taken and it's fair. And I think the only thing we can do, as with any science, so it's not specific to a biorepository, but with any science, is just make sure that we're, being conscious of the mission to advance health, and to do so in an equitable way, and continuing to be apprised of changes and think through the ethics of the changes that come. I don't know that I can give a better answer because honestly, there is a crystal ball factor here that makes all of this very challenging.
Yep. Yes, indeed. Thank you. And in the last minute or so, very briefly, two comments. The first one is about peer mentoring, specifically when it comes to opioid users. The question is, can opioid users that have walked away from the edge of a cliff in terms of their use and misuse serve to help others follow a similar trajectory of success? And the second comment, again, from the same participant is it possible to build biorepositories for pharmacies?
I can contribute a little on the first one. There's lots of different directions to go with that, but what it makes me think about with, I know that just in the last couple of months, the state of Michigan, MDHS, has expanded their resources towards peer recovery coaches quite a bit. So there's lots of different places within the health system that that type of professional can fit in. But one that's been modeled here some at University of Michigan, and Chad, I don't know if this is specifically an opioid use case sub-project, but Gina Dallum's, its root is what it is. I forgot what it stands for, but overdose response team, essentially. So when someone's had an overdose, having a peer recovery coach / patient navigator reach out and help them identify where to, how to overcome some of the self-stigma issues that are with addiction and help overcome barriers to getting into treatment with that person when they're at this critical juncture where they've just survived an overdose.
Thank you. And about the biorepositories for pharmacies, any thoughts?
So I think that's a great idea. I think that the challenge with, I believe that there is a resource to get prescription data from pharmacies as a potential additional source to link to this genetic information. I have not personally used that, but I think obviously the more data that we can get from participants with genetic information, the better questions we can ask and answer.
Great, thank you. Well, we've reached the end of the session. I don't see very many remaining questions, so this is probably a good time to wrap it up. In the presentations that we saw, in the very lively discussion we had at the end, we saw a very interesting blend of biomedical challenges coupled with a number of opportunities to innovate in predicting adverse drug interactions, modeling genetic traits, translating some basic science, discoveries into clinical practice, and so forth. I also want to mention that because of privacy concerns, we did not have a chance on this webinar to address specific individual health-related questions. Now, we obviously recommend that all participants interested in health consultations address these with their primary care physicians or Michigan medicine specialists or whoever they are referred to by their primary physicians. We're getting closer to the end of this specific time together, but before we go, we would like to thank all of you for the participation in this year's health research, as well as in prior years, and for attending the webinar today. We hope that this was informative and interesting for you the way it was for us to hear some of your thoughts and questions and comments. And if you have any subsequent questions or need any assistance or help from Precision Health, please do visit our website, precisionhealth.umich.edu. Send us a message via chat. We love to hear from you, connect with you at any point in time. If you have ideas for future webinars, meetings, connections, researcher and participant get-togethers, exchange of ideas, and so forth, please do submit those either through the chat now or through email to our great organizer, Tina Gruger. Her email is tcreguer @umich.edu. We always welcome your thoughts. And I also want to thank the speakers, the presenters, the panelists who delivered such an interesting information about their research, the entire program, and engaged with the participants in the live discussions. Special thanks to Tina Gruger for making this event possible. It was a difficult thing to put together, but Tina stepped up and did a great job. We will be sharing the recorded event in a few weeks, and we'll send out to all who registered a URL link where you can refer to and watch some of the presentations at a later time. So thank you very much again connecting with us, and we hope to see you very soon at another event.